several months. And the delay has been caused by a lot of reasons, mostly a lack of speakers, but we're back. We're very privileged to have Dr. Allie Tran with us this morning. And she is going to be hosted by Dr. Mary Dolansky. So Mary, as you guys all know, is one of the multiple PIs for the UH Advanced Center, advancing diagnosis um, well, I should know the acronym myself, right? To validated analytics and novel collaborations for excellence. And Dr. Ali Tran is a research scientist, a nurse scientist at the MedStar Research Institute, which is very engaged in the Diagnostic Centers of Excellence initiative. Most excitingly, Ali has also been a fellow with the Society to Improve Diagnosis in Medicine, which has very strong connections to all of the diagnostic centers of excellence. In fact, I don't see Kathy McDonald on here, but she heads up the center at Johns Hopkins, and together with me, David Newman Toker, and several others, we helped found the society back in 2009, long before Allie's time, I think. But anyway, with that introduction, Mary, I'll maybe ask you to take it over from here.
Great. Thank you so much. And it is such a privilege to have Dr. Tran here today to talk with us about her career and entrance into this area. So maybe, Allie, if you could give us a little background in your nursing career and sort of how you landed as a CITM fellow and doing this work in diagnostic excellence for older adults.
Sure, Marian. First off, thanks for having me here. This is one of my favorite topics to talk about within diagnostic safeties, and I can go on whatever tangent thou shall wish. So, so I'm a senior research scientist at the MedStar Institute for Quality and Safety, formerly trained as a health services researcher and a critical care nurse. I've been involved in research and quality improvement, and especially interprofessional education and research, kind of from the beginning of my career as a, new grad registered nurse in critical care. I joined MedStar through the Institute for Quality and Safety in 2022, and then there have supported a team with work funded by a 5-year contract from the Agency for Healthcare Research and Quality to develop resources to build diagnostic safety capacity in the US. And so through that work and a lot of it and work through that space, I've been really interested in how nursing intersects with diagnostic safety and ways to better leverage nurses, particularly RNs and LPNs and kind of, non-advanced practiced nurses in diagnostic safety efforts. And then as far as, so that's kind of my one track within nursing. And then the other track is, sometimes in health services research, it's really important to think through, like, what are some of the unique challenges for a particular patient population, not just kind of, health services research widely. And so when I reflect on, my career and kind of look at the common thread of a patient population and what I've been most excited about, and what I've had the most experience in, it's always been around older adults. One of my first jobs as a high school student was working in, an activities center at a nursing facility for residents with Alzheimer's. And then my first research role was around older adults work and neuropsychology. And then I've been teaching in older adult health spaces and clinical for a bit. So that's kind of, this, and we'll talk about a fellowship, but kind of merges my two interests. There's the nursing part, and then there's the kind of older adult unique challenges related to the older adults in diagnostic excellence. So.
Yeah, what a great journey. And I know that you graduated from the University of North Carolina, which has a great health services, research scientist program. And then also notably, you were a Robert Wood Johnson Foundation Future of Nursing Scholar. So these are some great, opportunities that you engaged in and led the foundation for you sort of in this work as a scientist. What are your observations in clinical care that led you to thinking about diagnosis as a nurse and the opportunities for improving care for older adults?
Yeah, so, historically, I think I had never really thought about a lot of the work we've been doing as diagnosis or the diagnostic process. Marian, I know you talked a little bit about this in your last webinar in this series, but as nurses, when you're being trained, you're taught, we're not diagnosticians. Medical diagnoses are made by diagnosticians and advanced care providers. And so there's almost a lot of effort to kind of not mention medical diagnoses or be involved in the diagnostic process. I will say with my work through MIQS and kind of, the shift in thinking around the diagnostic team and the diagnostic process, when I reflect on some of the earlier work I've done, either around like sepsis, early sepsis identification and
Mhm.
treatment, that really is nurses' contributions to the diagnostic process. How are nurses aware of what are early signs and symptoms to be aware of? For us, it was we did a simulation. It was looking at like delirium and the identification of delirium and who considers sepsis, like at what point, in this simulation point. And for that, it can be, nurses, it can be patients, it can be physicians, it can be escalated care. But the point is, we really want to be able to identify that as early as possible. And if the concept of diagnosis is a shared conceptual model across the team, there are different people who have different pieces of information and insights that can contribute to really elevating diagnostic safety there.
Great. That's a neat journey. I think that it demonstrates how you have changed your lens, as a nurse, from providing kind of individual care to thinking about the system of care and how nurses contribute to that system of care and sort of systems thinking and awareness, which is really key in this teamwork or team efforts in diagnostic excellence. How was your CITM fellowship? Tell us a little bit about it. How is it now adding to your work and your thinking and you're advancing our science in this area?
Yeah, so the CITM fellowship, just for some context, is a 1-year fellowship. It's really designed to enhance like knowledge and skills in diagnostic quality and safety. You get matched with a mentor and recognized leaders in this field, and it's designed to help you develop and implement your own projects. This year, I was very fortunate to be selected as the Age-Friendly Care Diagnostic Fellow,
Hmm.
so have additional support with the John A. Hartford Foundation, which has really kind of opened up opportunities for me to really dig into this older adult diagnostic safety space. Um, and so my work in the CITM Fellowship kind of bridges together those two interests that I had talked about from the beginning. So the one track is, my work at MedStar and my clinical experience and experience in QI, and kind of this notion that older adults are at a higher risk for diagnostic errors for a number of reasons. And so how do we really better understand kind of the state of the science and what those risk factors are? And then the second is around, leveraging nurses in diagnostic safety efforts and quality improvement. So I really feel more and more as I dig into this that nurses are a really untapped resource in diagnostic safety. They have the greatest bedside presence of any healthcare member. Sometimes in some settings, they're the only on-site healthcare provider, especially where older adults can reside. And then they're also the largest healthcare workforce in the US and consistently rated, one of the most trusted professions. And so really this work is how do we better leverage nurses or understand what some of the barriers are for leveraging nurses in diagnostic safety efforts to improve kind of the unique challenges that older adults might face throughout their care and care continuum.
That sounds like a lot of your work was critical care and hospital based of systems perspectives, but it seems like you've done some work in ambulatory care too. Do you think the nurse has a role in the ambulatory care setting or community setting?
Yeah, absolutely. Actually, my mother was a nursing supervisor in an assisted living for the bulk of, her career here in the US. And so I've had a lot of kind of firsthand experience, and I had volunteered and, was involved. So prior to being a clinical professional too, of what the value is of nurses, identifying when something maybe needs to be further evaluated, and or if there's a new acute problem that's happening or an acute change and that needs to be worked up for a diagnosis. And then also, in teaching older adult health and doing some of my work in ambulatory care settings, I mean, there really is, nurses are often the first kind of point of interaction in really trying to help patients or the complaints or concerns that they have and communicate them in a way that aids the diagnostic process for like diagnosticians.
So it seems like getting the word out to nurses and getting them thinking about this area is really important. I think you mentioned to me when we talked earlier, you do some interesting design thinking work for diagnostic safety. Want to share a little bit about that?
Yeah, so part of so I'll go back to the SIDM Fellowship project in particular because this kind of relates to so for that 1 year project, there's kind of 3 aims that we have. And so the first is, kind of describing the state of the science in the older adult diagnostic work, which is kind of coupled with some of the work we're doing through this contract, and really trying to understand in the literature what's known about diagnostic errors and challenges that are unique to the older adult population. Then the second aim is utilizing, a lot of safety efforts don't include the detection of, diagnostic errors currently. And so a lot of the recommendations for kind of building capacity as a system is to utilize existing, either quality and safety reports or case review data and really hone in on diagnostic errors. And so kind of in that vein, we're looking at case review data from, our 10 hospital health system to identify vignettes or examples of nursing contributions to diagnostic excellence. And then the third part is, there's been a lot about bringing in nurses or, helping nurses to understand, and we can talk a little bit more about this later, but helping nurses to understand their role and contributions in diagnostic errors. But I'm curious, like, what do actual, direct care nurses of all varying kind of levels think with, the new NAM report, Improving Diagnosis? What do they think about with the conceptual model and the reconceptualization of diagnosis? And so part of that work is utilizing, previously in my pre-doc program, I was trained in healthcare design thinking and for developing innovation. And so it's recruiting and working with direct care nurses in, design thinking workshops to kind of co-design a practical nurse-led diagnostic safety checklist to improve diagnostic safety. And so, and with design thinking, for those who aren't familiar, design thinking, it's really rooted in human-centered design. It's an approach to innovation that's been utilized in a lot of different fields, is a little bit newer to come to healthcare. And the premise of it is it really starts with people. It's all about the intentional inclusion of really divergent perspectives of the people who are going to be the end users of your, design. I think too often, a bunch of people go into a room and they design something and then they have their prototype and they come out. But with design thinking, to be truly successful and really develop an innovation that works, it's about gathering those people kind of early on and then going through a process where you're drawing from their real world experiences and whatnot. And actually, this might be a good time, Mary, since you asked, I'll share my screen just for those who are not familiar. Just like a very kind of simple stage process around design thinking. This comes from Penn Nursing. It's kind of and the website is there. It's a course designed for healthcare providers to really understand and utilize design thinking in their settings. And so kind of like the 5-step process here is the first step is really, like I said, gathering these divergent perspectives, really trying to draw on people's real world experiences to address whatever the modern challenge or problem is. You'll notice then the second state is then to define the specific problem. So oftentimes as, innovation, we come in and we say, oh, this is the problem, and this is, what we need to work on. And by really focusing on an empathy stage, sometimes the problem ends up being something that you didn't really actually think it was for the end users, and you end up defining a different kind of problem in order to design the innovation. And then, the next phase around ideation. And so this is around thinking in collectively around as many ideas as possible. And this is what I kind of call the yes and phase. Like there's no, oh, that won't work in practice because of XYZ. It's really just generating ideas and saying, okay, yes, if that worked, and we should consider this, and it's building collectively off of the ideas that are shared within the group. And then it's the cycle of developing a prototype, testing, and then oftentimes repeating that multiple times. So that's essentially what we're doing with kind of developing a checklist or ways to, what I envision a checklist, but who knows what will end up being emerged from our design thinking workshop. It could be something else, but ways to engage nursing in the diagnostic process in ways that they think are applicable to their work and relevant.
Yeah, that's really neat. That's a great site, that Penn site. Their course is really very innovative and interactive, and it's web-based and free. It's really great that they have that. I love the fact that you've done this design thinking integration into your, fellowship. Just for the people on the call, we have a part of our clinical translational science collaborative, a design studio option. I don't think it's up and running yet because our grant was just funded recently, but that will be service or resource that we can all use. So we could go into the studio and do some design thinking with patients, to look about this issue of diagnostic excellence and getting that patient voice really heard. It might be really neat for our future.
Yeah, that's great, Mary. I mean, it's fun too. Whenever we've done these, I've done them at MedStar and I've done them, when I was at UNC. It's people end up, I mean, the idea is to end up feeling excited about it, and they end up being really fun. And there's always something that comes up that you hadn't considered,
Yeah.
or that the group hadn't considered. So it's really exciting and fun to kind of
Yeah.
go through that. And it really does generate, I think, innovation that is meaningful and and able to be implemented better within practice.
Yeah. We also used it in our sepsis component of the advanced center, where we were thinking about the practice problem of why the healthcare professional team doesn't huddle about the data that's coming in about the potential for sepsis. And so we did like an invasion in the ER, and there was about 8 of us who had like our boards, and we moved them all around in sort of a real time design thinking activity. So it was sort of interesting.
Yeah.
But that's really neat. So I also am very curious about this issue of nurses not understanding or aware of the role of their contributions in the systems in which we work as nurses. Can you just share a little bit about maybe what your thoughts are on that, and maybe next steps that you'll lead forward?
Yeah. So scope of practice and nursing scope of practice is, I think, one of several of the challenges within here. I remember, in nursing school when I trained, it was, we developed these care plans, and they're always around, well, you can't really use medical terminology in a nursing care plan. You really need to identify kind of nursing diagnoses of problems that are related to, medical stuff. And so I think that there's this almost like hesitation to really include medical terminology and nursing's role and contributions to medical terminology. And then in practice, especially where I trained within critical care, I trained in a large academic medical center, and oftentimes residents asked nurses for, what they thought might be going on, or if there was something else to consider, or especially experienced nurses were like, I'm not really sure if they're responding to this treatment. Like, do we think there's something else potentially going on that we're missing? And it's that dialogue and conversation, even though, nurse isn't responsible for the diagnosis and the contributing to the diagnosis, but it's sharing that kind of cognitive model, and that just like distributed cognitive process around diagnoses, and sharing collaboration and the sharing of information that informs diagnoses. That's really, I think, important. And so, you know, especially in like certain areas that nurses work and practice in really regularly, they can become potentially more familiar with some of the either common patterns or diagnoses that exist, and can be really valuable healthcare team members in, areas that are especially training or kind of working on like teaching like residents and physicians and folks around diagnosis. That said, too, there's been a lot of work within this space. I think about, and I have, I think on one of these slides, a couple of issue briefs that have been done around this, around kind of calls to action around nursing education or nursing in practice, and ways to kind of describe how the diagnostic team is being kind of reconceptualized in some ways as a more team environment.
Mhm.
I think Dr. Gleason, a colleague of mine at Hopkins, has written, I think, a nice paper in 2017 around a conceptual framework around nursing role in diagnoses and within their scope of practice. That kind of includes a variety of different nursing tasks that are really important. Diagnostic triage, interprofessional teamwork. So like we had said with the kind of surveillance that nurses do, or the efforts that nurses have to improve system surveillance, closing the loop through care coordination, making sure patients follow up and follow through with the key tasks and activities that are necessary for achieving an accurate and timely diagnosis. And then also, empowering patients. So I mentioned earlier, like nurses are consistently ranked, the most trusted profession in the US, I think for over 20 years now by Gallup polls. I kind of joke, even if I'm not clinically practicing, I exist on call for friends and communities and colleagues as like, should I go to see a doctor about this? And like what? And that really is, when we think about the diagnostic process, that's the start. When does somebody choose
Mhm.
and decide to access care, and with what information? And so I really think nurses, being such a large proportion of the healthcare workforce, really need to understand their roles within that space. So I think, and I'll put a plug. I mean, there's lots of papers on this. There's kinds of a few different calls to action. I have led an issue brief looking at pragmatic ways to involve nursing in hospitals and ambulatory care settings for nursing leaders and nursing educators to kind of get the word out around the diagnostic role. And I think hopefully from this project, we can learn a little bit more from the perspectives of direct care nurses about, what are some of the challenges and barriers to being involved in diagnostic safety efforts, or how do we leverage what nurses are already doing, and already feel our contributions to the diagnostic safety initiatives in ways that we can translate a little bit more and scale up.
Yeah, that's great. Really, really excellent points. And maybe we'll take a pause just to see if anybody on the call would like to ask any questions or curious about any of Dr. Tran's work.
Sure, Mary. Thank you, Allie. Fantastic presentation, and congratulations on the CITM Fellowship. Two questions. One was, one of the means by which I rely upon nurses in the diagnostic process is educating patients about diagnostic testing, for example. So for example, in cardiovascular prevention, a lot of our patients have coronary artery calcium scans. And, beyond, I don't know where they actually have to go or how they sign up for it. Nurses are very highly skilled in explaining to them exactly what to expect during that. And I think that could be a really, really valuable role. Um,
Mhm.
the other question I had for both Mary and for Allie is, what is the state of curricula now in nursing schools as far as being part of the diagnostic process?
Great point, Dr. Rao, and also a great question. I have talked to right now, there's a lot of curriculum changes, I think, happening and restructuring within nursing that I've heard of and been aware of, particularly in graduate school. And so I do think that the idea around diagnosis and diagnostic safety is translated well there. As far
Mhm.
as undergraduate, I haven't really seen that link made. And I'd love to hear, with your experience, Mary, like your thoughts on better, you know, emphasizing that or moving that forward.
Yeah, I don't think we do it well. I don't think nurses understand the percentage of misdiagnosis and the issue of, um, diagnostic errors. I don't think they really understand the levity of that issue, and they don't think about it as a safety issue. They think about it as a physician issue, not really part of their work. So we do have a lot of work to do, I think, in the nursing curriculum.
Yeah. But I do think it parallels nicely too with a lot of kind of the safety, when To Err is Human, the first NAM report, came out. I think that shift in, like, it's not a punitive, safety behavior, it's really looking collectively at systems. And I think now looking at diagnosis, I mean, looking at kind of, tasks that historically have been viewed as the role and responsibility of, a team leader or a diagnostician are now spread where even, I mean, patients are important team members of the diagnostic process. Artificial intelligence has the potential to be an important member of the diagnostic process and the diagnostic team. And, the ability for patients to cite and sort through information and come to their providers in informed ways are empowered and good, important members of the diagnostic team. So I think it will take some time. I think a lot of these, writings and conversations and the dissemination around this is a good start, and I look forward to when this becomes a main part of a curriculum.
I agree. Well, thank you, Allie, so much. I think we're out of
Allie.
time. Right. We love your thoughts about ground up driving change in diagnostic safety and nursing practice.
Right. Thanks for having me.
Thank you for coming, and thanks to all. Have a wonderful day.
Thanks.